We're back in room 6, and I know this is another controversial session that we're doing. And this is a patient who I'm going to ask Dr. Sandeep Singla to present the case for Dr. Marin and Dr. Zeller to have the debate.
Next slide, please. Good evening. So we have a 82-year-old man with the multiple risk factors. He's a hypertensive diabetic. He currently smokes about a pack a day, severe COPD, CKD with a baseline creatinine in the range of 1.4 to 1.6. And he presented with a worsening right lower extremity claudication over last 1 year. We did ABIs, which were done at outside hospital, and they were reported as 0.69 on the right, and the left ABI was 0.92. He did have an angiogram at the outside facility where they reported there's a possible stenosis in the right iliac, possibly external iliac, and then tight stenosis in the common femoral. And they told us that SFA was a mild disease with a 2-vessel runoff below knee. Next. So he was referred for further evaluation, and when he was referred to us, we offered him a hybrid approach with the CFA and atherectomy, and then possible stenting for the external iliac stenosis if it was severe enough. Patient.
No, don't just go on.
Okay, and then we offered him, and then patient initially declined surgery, and then. Coming back to his labs, he has the only significant thing is a creat of 1.5, and when we first saw him, we did put him on pletal. We increased from 50 to 100, but he was still having severe claudication, unable to walk more than a block, at the most block and a half.
So I just want to go over the angiogram, what we did. So he has eccentric common femoral artery stenosis, as you can see here. He also had external iliac artery stenosis, which we had balloon angioplasty up top. I want to show it to you. So we balloon angioplasty the external to get the sheath across. Wasn't really 90-95%. It was really moderate disease. We didn't want to go, and the gradient was only 5 millimeters across it. But we did balloon it because we didn't want to dissect as we came across. And then, so you can see here you have eccentric lesion. Looks like he's been instrumented at some point, as you can see by the ulceration. And as far as runoff is concerned, it was 2-vessel runoff with the SFA, and I just want to show that because I know the debate is going to take place. So you can see here the SFA was really just mild diffuse disease, and you can see here the popliteal again was patent, posterior tibia is occluded. Perineal has some stenosis, and the foot vessels, again, because of the creatinine, we did take full stepwise, but shows you have excellent flow into the foot. So go to the intravascular ultrasound, guys. So the intravascular ultrasound coming back from the SFA back, again, shows and convinces me that he's been instrumented at some point. As you can see here, he has some plaquing in the SFA. There's your bifurcation. And as you come into the common femoral, he has severe plaque in the common femoral. And then as you keep pulling back towards the external, you can see clearly that you'll see a double lumen with a dissection, and then multiple dissections there at the level of the common femoral. Whether that's a ruptured plaque or not, I'm not sure. Again, you have some plaque, and then back into the normal external artery. So at this stage, we're here, and planning on doing this. I don't want to say what we're going to do, but obviously the patient has declined surgery. We're going to do an endo approach. What we were thinking at this stage was to go ahead and do a directional atherectomy followed by drug-coated balloon angioplasty. Our reference vessel diameter in the common femoral is a 7, I believe, guys, or 6, 6.8? 6.8 in the common femoral artery. So that was going to be, and if you look at the RAO angiogram, to show you that it's far away from the profunda. I'm just going to take one picture here just to show you that it's I have the profunda is not involved. So this way you can be rest assured that it's a body of the common femoral and it has nothing to do with the bifurcation. So while you guys talk, I'm just going to go ahead and start the case.
Okay, PK, I think that's an excellent plan, and I think this patient really makes the following discussion, debate very clear. So I would like to invite Thomas Zeller now. He is going to speak about endovascular treatment of the common femoral artery in 2018, ready for prime time.
Well, of course it is. Well, and this is the optimal case for atherectomy and followed by drug-coated balloon angioplasty. So probably I can get my slides.
Well, thank you very much for this passionate discussion, and I think all the arguments are well taken. I think currently we are really lacking
Am I up?
the data for any conclusive positioning here. But still, there is a point here which is audience vote. I don't know if we can do that, but maybe PK, maybe I can ask the audience still. Let's say with a 5 years perspective, I mean, maybe you can vote now who thinks that the majority of patients, not all patients, but the majority of patients will be done in 5 years endovascularly. Raise your hand. And who thinks the opposite? Okay. Well, you are in an interventional environment, so the majority is clearly believing that even that very, let's say, simple and effective surgical procedure eventually may become less invasive. So, PK, what have you done with your patient?
So, Dirk, I think I just want to point out some of the points that Dr. Marin and Dr. Zello said, that the reason why we chose this case. I mean, obviously the profunda and the SFA were not involved. There was no extension of disease into the bifurcation, which I believe makes it a much more complicated endovascular intervention, which I think at this time we may not have the tools to handle that type of lesion. So this is the pre-picture. So we decided to do directional atherectomy. So you can see after directional atherectomy, it's not the prettiest image, but clearly we're able to get a lot of the plaque out. So can you show the IVUS after directional atherectomy, please? Which is the second run. So the IVUS after the directional atherectomy showed, is this the final or the one before this? I need the one before this. So we did IVUS, which showed that clearly that there was still plaque there, but we were able to debulk a lot of the plaque and were able to, get rid of much of the dissection plane that was present at the time. So at this stage, what we decided to do, again, for the sake of time, I'm going to have to skip. Come on, guys. Oh, there it is. Okay, here we go. So you can see here, as the directional atherectomy is coming, as the IVUS is coming from the SFA, you can see here that it's not a very, very pretty picture at all. Clearly, it still looks like there's plaque, but our lumen is a lot larger, especially at the level of the distal common femoral artery, and there's still a double lumen at this site, and we know that we were in the true wire, and we have a bigger lumen at the proximal common femoral as well. So then what we did was we did a pre-dilatation with a 6-0. And again, I think the reason we did that was to prevent dissection, because at this stage, I mean, not that stenting is something that we want to do. I think in this patient, we could get away without stenting. So we did a 6-0 for about 3.5 minutes while they were talking. And then we took a picture after the 6-0 balloon dilatation, as you can see, looking pretty good. So at this stage, we wanted to apply drugs, so we added a 7-0 Lutonix balloon. We did a 7-0, we added drug-coated balloon 7-0-40, and we left it up for 5 minutes. So after the 5-minute balloon, I want to show you what we did. This is the final picture in the RAO view. He moved a little bit. And then you can see in the LAO view where you show the eccentric common femoral lesion, you see at this stage how it looks. You really have no problems with wonderful flow with no dissection. Now I'm going to show you the IVUS. And as we all, as cardiologists and vascular surgeons, we know IVUS always, makes it look much different than the angiogram. You can see intravascular ultrasound-wise, the SFA we never touched. We never entered the balloon into the SFA. The distal common femoral, this is the distal common femoral right there. No involvement of the profunda. And you can see the plaque has been clearly pushed back. And you can see here, there was a flap that was present. I believe that's the ulceration, but there's a much better lumen with no compromise of the lumen and no free flow, free flap. So then we took some distal runoffs here, and I just want to show you the final picture. So you can see here, we have excellent flow in the common femoral, no evidence of flow-limiting dissection, and I think we're going to stop here because the runoff is phenomenal, and we're going to be done with this case.
A great job. PK is a great case, and I'll say before